how do you take fearing inaction more so than failure and actually integrate that into the culture of the organization, proliferate that across 45,000 plus employees, 14 systems?
Our innovation strategy is our quality strategy, is our IT strategy, is our virtual health strategy. We all together stack hands and decide this is a priority and this is what we're going to do. If we're going to give a doctor or nurse one more thing to do, we're going to take two things away. We don't do pilots because I think that innovation gets suffocated by pilotitis. We do phased deployments. And we use our integrated healthcare system as a learning laboratory. 14 hospitals. We have a megatropolis quaternary academic hospital, regional medical centers, community hospitals, and small and critical access hospitals. So everything that exists in American healthcare, we have in our system. We use our system as a learning laboratory. So we do differences in differences, implementation science, and we think about how to optimize and scale.
Welcome to the Analyzing Healthcare podcast, brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
Welcome to the next episode of Scale Community's Technology and Innovation Within Healthcare podcast, where I am pleased to be joined by Richard Zane, the Chief Medical and Chief Innovation Officer at UC University of Colorado Health. UC Health is a 14-hospital system in Colorado with, I believe, Richard, over 45,000 employees and about $9 billion in annual revenue. Is that correct?
That's correct.
So why don't we begin maybe by just understanding the mandate within the UC Health system? I think the word innovation can mean lots of different things, and we explore that word in many different angles on this podcast. So what is the role of the innovation office at UC Health? What is the role of the Chief Innovation Officer at UC Health?
So let me just take a step back, if I can, and
Sure.
I'll just give you an overview of how we're organized, and that'll give us the context on how we approach innovation. So as you mentioned, we're a 14-hospital system based in Colorado. We're relatively new, having started in 2012. And in contrast to many other large healthcare systems, we are an operating company, not a holding company, which means that we have guiding principles around how to use systemness to advance the journey of our patients and improve quality and care delivery. The reason why that's important is we say things over and over again, like we are patient-centered, data-driven, believe in system discipline and local control, which means that what's important to a patient in Yampa Valley, Colorado is also important to a patient in Aurora, Colorado, and in Colorado Springs. And with exceptionally rare circumstance, all of our patients, regardless of where they are, have 23 pairs of chromosomes, 2 lungs, 4 chambers, and a heart. You sort of get the point. So innovation is a strategic pillar for us. And as you alluded to, innovation can mean everything and nothing. And for us, innovation means intelligence, another term that means everything and nothing. And for us, it's making better decisions in healthcare. And those better decisions could be choosing pharmacotherapy at the bedside. It could be how to better organize and operate operating rooms, how to do capacity management, how to automate revenue cycle, how to automate staffing, really across the spectrum. Our approach is hyper-pragmatic, which means we start with a problem statement. What problem is it that we're trying to solve? And the best problem statements are the ones that come from the people who are doing the work, the people at the front lines. And when we identify a problem statement, we go through a pretty rigorous process of validating that this problem actually exists. And if it's a problem for us, it's a problem for the other 2,000 systems in the country, which means let's see if anybody else has solved it, because there is no use innovating and starting something from scratch if it already exists. So we'll learn from other places, and if they've solved it, we'll adapt or adopt and iterate. If they haven't, then it's a problem that hasn't been solved. And we try and decide that if it's solvable or not, because there are lots of problems that aren't solvable, and we're not going to spend a lot of time and resource solving the unsolvable problems. And we'll do an environmental scan. So essentially we'll say what companies are in this space, either adjacent to this space and already in healthcare, or in this space and not in healthcare. And we'll have a conversation with them. And in the ideal world, where we identify a company with whom we'll partner, we'll do three things. We will think about the problem statement and we'll want to be a customer of whatever product we develop together. We want to be a co-developer, and then we want to participate in value creation. So that's our approach from a high level.
There's a lot to unpack there, and I want to spend a lot more time going through examples, and I want to spend a lot more time on what you've already outlined in terms of the process and framework. But just a couple more questions to put the role in context. There's a couple components of what you said that I think are particularly interesting. So first question is, what percentage of these problem statements are requiring technology as a solution? So is the innovation technology focused, or is it much broader than technology? So is it 25%, 75%, 50% technology?
So what I don't want to be is the gatekeeper for anything innovative. So when people have an innovative solution to a problem, they don't need my permission to solve it. They may need my help. They may need my endorsement. They may need access to resources, but they definitely don't need my permission. So in my role as chief medical officer, I do a lot of work where we iterate and innovate around a problem statement that may not require technology. In my chief innovation officer role, it's usually the overlap of where there's a problem statement that may have a solution that involves technology.
That makes sense. And actually, that gets me to my next question, which I think is very interesting, that you're both the chief medical officer and the chief innovation officer. And I would just love to hear how that came to be and what the synergies are between those two roles. It tells me a lot about how UC Health is thinking about delivering care and excellence in care delivery if they're linking chief medical officer focused on quality, safety, patient outcomes with chief innovation officer focused on technology. But I would love to hear from you, your perspective on that.
Well, I agree with you. I think it's both novel and opportune and deliberate. It's not an accident. I've been in the chief medical officer role for 6 days now, so relatively new. Prior to being chief medical officer, I was the chief innovation officer, but I was also the chair of the academic department of emergency medicine. So there's always been a duality to the chief innovation officer role here at UC Health. And as chair of the Department of Emergency Medicine, I had oversight for 350 faculty, 27 urgent care centers, 25 emergency departments, and a very large virtual health platform, which included almost 600 FTEs, which is still my responsibility. So the combination of having a physician leader who's responsible for a large footprint of care delivery be the chief innovation officer is really the theme. And now as chief medical officer, I have a larger responsibility for a larger footprint of care delivery. And it's really the notion that we can't continue to do things the same way and expect improved outcomes. That's really the overarching theme is innovation is not just shiny objects and not just technology. It's really approaching a problem or a set of circumstances a different way. And sometimes that involves technology. Frequently, it does not involve technology. But it's on purpose that this is a dual role and it's deliberate.
Let's talk about where innovation, technology innovation sits in the priority stack for the health system holistically. I think of 14 hospitals, I think of 45,000 employees, I think of $9 billion in revenue. And I imagine anyone in that case is going to say there's plenty of innovation, that's the way of the future. But I would imagine 9 out of 10 get stopped by the day-to-day when it comes to innovation, whether it's a underperforming or over burdened expense structure, underperforming service line across the system, or some new growth and development opportunity. There's always some distraction, fundraising, community relations. And so at the board level, at the CEO, CFO level, where does this innovation fit within the UC Health system priority stack?
It is one of our 4 key strategic pillars. It is unambiguous that being innovative is a core principle and core to our identity and core to how we believe we are going to differentiate in care delivery. Part of it is that we're relatively new. We're a relatively new healthcare system, which is both good, more good than bad, but mostly good. And we don't suffer from that this is the way we've done it for 100 years. Like that doesn't happen here. It's not a part of the conversation. And technology is not the be all or end all to everything, but it is a tool. And healthcare delivery is people, process, and tools. So if the tool involves technology, then we want to make sure that it's sustainable technology. We want to make sure that it's reliable technology. We want to make sure that it makes our patients' lives better and our providers' lives easier. That's essentially the guiding principles of how we behave around technology, right? It should be easier, not harder, fewer clicks, not more clicks, path of least resistance, bulletproof, right? And that's how we approach it. Sometimes it's a 90% technology solution. Sometimes it's a 2% technology solution.
I do think it's interesting that the system formed in 2012, and within a relatively short amount of time, you've reached the scale that you've reached. Would love to just hear how the system formed in brief context, because I think that your comment about forming recently and not having a lot of embedded history and allowing that to put you at the front of innovation is interesting.
So in 2012, University of Colorado Hospital, which was the only academic teaching hospital in Colorado, joined with Poudre Valley Health System in northern Colorado and formed the basis of UC Health. At the time, except for Boulder Community Health, which is a small 2-hospital system in Boulder, Colorado, and Denver Health, which is a city-owned safety net county hospital in Denver, all of the other healthcare assets in Colorado were from out of state. HCA, which is based in Tennessee, Advent Health based in Florida, Common Spirit based in Chicago, Intermountain based in Utah. So we were the only Colorado-based system here. And then we soon absorbed Memorial Hospital. And then we became 14 hospitals. What's also interesting is of our 14 hospitals, 6 are from the ground up builds. So it did not exist prior to becoming a system. That's unprecedented in the United States. Coincident with that was a pretty remarkable growth in the population of the state of Colorado pre-pandemic, and everything seems to be pre and post-pandemic. Pre-pandemic, depending on whose embellishment you believed, the state of Colorado grew by 7,000 to 9,000 people per month for a period of 10 years. So there was an unmet need for healthcare delivery, and we met that need.
So it sounds like a pretty innovative health system holistically, not just when it comes to technology, but 6 de novo hospitals, about half of your footprint is another form of innovation and quite unique, as you say. I want to jump into the meat and the substance of innovation and really go into a couple examples, but where does that spirit of innovation at UC Health come from?
It comes from, like many things, it comes from the top. So the CEO she's a remarkable leader, but she's unapologetic about embracing a new way to do things and a different approach. And our board is quite enthusiastic about, one, serving Colorado. There's an unapologetic statement that we are not-for-profit based in Colorado and exist for Coloradans, and that we must deliver care in a way that is better, faster, and more local.
Very interesting. All right, so let's jump into the meat. So take us under the hood of the innovation office at UC Health. Where are you focusing your time, attention, and resources thematically? And maybe if you could walk us through a couple of examples of successful and perhaps unsuccessful initiatives within the system from an innovation perspective.
Yeah, no, I'd be happy to. Let me tell you a little bit how we're structured. So as Chief Innovation Officer, I report directly to the CEO and attend all the health system board meetings. And as CMO, I do as well. Under my leadership, we have a team of mostly engineers and process improvement specialists and project managers. That team spends half their time implementing innovation initiatives across the system, and the other half of their time leading cross-service or cross-institutional high-priority projects. The reason that's important is because the people who are leading innovation are also the people who get assigned the most challenging problems in the system. So they know how the system works. They are called on often when there's a difficult or nearly unsolvable problem. And that creates a self-fulfilling prophecy of when we are bringing a novel technology or a new something to the bedside or to our health system, there's a credibility to the people that are doing it because they've done other things, not just new things. And the optics are high because it sits at the board level and the CEO level. Mm-hmm. So I'll give you an example. And this is one of my favorite examples because it is right in our bailiwick of improving quality, saving lives, and using technology. So there was a project a number of years ago called the Haystack project, and it was led by the chief medical officer or the chief quality officer, now the chief medical officer in our northern Colorado region, where she was trying to organize around the ability to keep track of incidental findings. So for instance, the Haystack project, needle in a haystack. How do you keep track of needles in a haystack? The problem was you get a chest x-ray, and on the chest x-ray, you have an incidental finding, right? Think of a nodule. And the recommendation is you should get another chest x-ray in a year, or you should get a CAT scan in a month, or you need something in the future. The way that was kept track of was highly variable, to say the least. So you could either get a letter from the radiologist that went to your primary care physician, you could get a letter to you could get something noted in your medical record. And there wasn't a lot of discipline around how we kept track of it. So that was the problem statement. Incidental findings, how do we keep track of it? How do we have closed loop communication? And how do we do the actual care? That was presented to the innovation team. And we did a landscape analysis. And coincident with that, she actually found a company that did this. And the company was called UCHealth. And we did a partnership with UCHealth. And we became a customer, co-developer, and we invested in the company. So our sort of trio of innovation. And what we were able to do was using this company's proprietary computational linguistic technology, care managers, and then developing new modules, we now have the ability to keep track of incidental findings on chest x-ray, incidental findings on thyroid scans, incidental findings on pancreatic scans. And then we're developing cardiac valvular scans, calcium scores, and we're going to build mammography and pap smears. So that means if I were to extrapolate and be generous, thousands of previously unrecognized or early diagnosed cancers that would have been unrecognized or lost to follow-up or diagnosed at a later stage. That's one of the great examples that we have.
And how long ago did that project launch, and how long did the project take to go through the co-development prior to the go live?
So it launched just over 3 years ago. It went through our usual analysis. So if a company comes to us or we find a company, usually the CEO, depending on the size of the company, and their key scientist will meet with me and one or two members of my team. If they get past us and I don't get to say yes, but I do get to say no, then we do in parallel an evaluation with subject matter experts. So in this case, pulmonologists, chief quality officers, and our data team. Then a technical evaluation. So does their technology integrate with our technology, or can we integrate it? And then a financial analysis of the viability of the company, both from an investment perspective and also just a straightforward financial viability. And we try to do those in parallel instead of in series. And that took about 6 months. Actually, it took 4 months. And then we made the investment 2 months later, and we started using the technology. And then we began with their out-of-the-box technology, which was in pulmonary nodules. And then we built together thyroid, pancreas, and valves and calcium scores.
It's interesting. So how many engineers are sitting on your team, the in-house team?
14.
14. And how many projects would you estimate at any given point in time you're focused on implementing, whether it's through the in-house team or third parties?
Right now, I think we have 11 projects.
11?
Yes.
Got it. So would you say that it's 75-25 in terms of relying on third party versus in-house custom builds, or a different ratio?
What do you mean by custom builds?
So my understanding is the in-house team, you might build a solution to one of your problem sets in-house through your 14 engineers, or you might look to third-party solutions to leverage their technology and pilot and co-develop with them.
The vast majority are external. For the innovation projects, 95% of them are partnering with external companies. For the projects where we're implementing priorities across the system, it may not even involve technology. And that's the other half. And when I say engineers, I mean industrial engineers, project managers, computer scientists, not just people who are writing code.
One of the things that I think is interesting about adoption of technology in healthcare is that there are so many potential SKUs that could be relevant to the market. So it sounds like in this case, you found a third party who had a technology, they focus on pulmonology, your problem set was either broader or different than theirs. So they had a core solution that was relevant, but they were pointing it at a different part of the market, so a different SKU. And so you had this concept of co-development. I'm curious your thoughts on how realistic is it that a third-party company that will offer enough SKUs to cover the needs of a system like UC Health? Or is the reality that it's so individualized and customized that it's highly likely that for the foreseeable future, its co-development is going to be the way to go, because you've got to have that connectivity to the UC Health specific needs in order to actually get adoption?
That's a great question. So one, we are meticulous about making sure we understand our problem statement. So if I were to say that our process is to do a landscape analysis, that would be strategic, but we're often opportunistic, which means that a company will come to us and say, hey, we've got this solution to a problem. We are absolutely meticulous about our problem statement because it can't be just an isolated thing that only UC Health has. If it is, I'm not going to hire an outside company, and I'm certainly not going to build something together to solve only a problem that only we can have. That's unlikely, but I'm not going to do that because if I'm going to become reliable on this product, which I most assuredly am, it has to be scalable. So even though we are solving a problem for UC Health, we're building and co-developing for customers 2 through 2000. And that's really important because they, Our Lady of Faint Hope or Intermountain or some other system may not have the resources or the wherewithal that UC Health does. In fact, most places don't, as I say braggadociously. So we will get on a plane, we'll help other systems implement it, we'll create a playbook on how to implement it. And we need these companies to be scalable. Otherwise, the solution that we're relying upon is no longer useful.
So it's a two-pronged approach. You have a problem set for UC Health, and you want to make sure that the solution solves it, but then you also want to make sure that there's broader commercial viability for the solution outside of UC Health.
That's the only way it'll work.
And is that driven by a desire for UC Health to see the minority stakes that you take in these businesses monetize and grow in value? Or is that driven by wanting to see a partner that will continue to flourish so that they can continue to service the technology that they're providing to your health system? A little bit of both, something else?
The latter is primary, but it's nice to have the former as well. And I'll give you an example. When we demonstrate our outcomes of our investments and partnerships to our board, in big red numbers are the number of people who didn't die because we did what we did. They're very interested in the return on capital, but they're most interested in the execution on our strategy of improving lives.
So how successful have these products been, the outside of the UC Health system? So you mentioned, origins in pulmonology in this case, expansion over to a few different areas, thyroid and beyond. Those other products that have co-developed with UC Health, have they now been productized and deployed in other environments?
Yes. So Eon Health is across the country in dozens of other healthcare systems. Another company, Arrive Health, which we started as RX Review almost 7 years ago or 8 years ago, is now in the native Epic and the native Cerner and touches millions of lives every day. LeanTos, which is one of our first investments and partnerships, was just recapitalized by Bain Capital for $1 billion. And we've had some companies that have gone away as well. So not all of this is success after success. From a high level, this is what we say. We abhor bureaucracy, like we need to move fast at the cadence of industry. We create solutions that benefit people, and we fear inaction, not failure.
We'll come back to that cultural piece, which we touched upon, but I do want to spend more time on it because everything that you just said feels so counter to what we see in many healthcare organizations. And there's a reason for that, right? I mean, I think healthcare organizations are risk averse, slow moving, and for a reason. So I do want to spend more time on the culture around innovation in a second. But the rubric for evaluating the potential initiatives that come before your desk, it's got to solve the UC Health problem statement. It's got to have broader market applicability. What other criteria do you look at, or are those really the two fundamental questions and the ones you focus on?
Well, those are the two fundamental questions that will then get us to the second parts of the question, which is it a giant company? And if it's a giant company, can we participate in value creation? And if we can, are they going to have sufficient focus to work with us? Because if I'm working with Google or Microsoft, unless we do something that is billions of dollars, it's not going to move the needle for their board. That may not be what we're looking for. If it's 3 gals in a garage in Palo Alto, have they done this before? Do they have enough capital to sustain themselves for the next 2 years while we solve this? Have they done anything in healthcare before? We've worked with a lot of entrepreneurs who've built very successful companies. They've never been in healthcare before. If they've never been in healthcare, do they have the requisite insight to understand how much more arduous it is to do anything in healthcare than it is to do in any other technology vertical?
So you can choose the right problem set. You can partner with the right partner or the wrong partner. You can succeed in building the technology or fail. You can succeed in adopting and integrating that technology into your operations or fail. So there's different ways it can go at each stage. For some of the technologies that have not worked, what are the key drivers of failure? Why you haven't been able to successfully navigate through each of those milestones?
Let me just give an example, and I'm not going to name the company because it would be not fair. But we looked at a company that had what I thought was a gangbuster, best-in-class algorithm that predicted deterioration, which meant that if I could install this algorithm in our virtual health center, which looks at patients across our 14 hospitals and identifies people who are getting sicker, it would do this faster. So in vitro, so to speak, looking at the literature that supported this algorithm, if it was half as good as it was reported, we would save thousands of lives, or we would, prevent escalations of care, get people home, et cetera. They were FDA cleared, which means that I didn't have to get them through the FDA, which is arduous and difficult. And we thought it was ripe to be able to deploy this technology. Then the reality was that in order to deploy this technology, I needed permission from the vendors that do our monitoring. That was a haul to do that. Then I needed an aggregator and a connector. That was difficult. And then when we finally got it into production, it just didn't perform. The algorithm simply didn't perform as we expected it to. And that's a reason for the failure. The regulatory burden of the FDA did not allow the algorithm to improve because it's fixed and static. So the algorithm was learning and we could see it learning, but we could only use in production the first algorithm that was FDA cleared. Second was that the other technology companies upon whom we rely did not have to allow us to put this algorithm into their technology. That took almost a year to move forward. And then by the time we got it in, it just didn't perform the way we had hoped.
So you've got a fear in action, but not failure. And it's a very simple statement, but I'm curious how that manifests and how it gets institutionalized across your organization with 45,000 employees. When you think about innovation, I think about reserving capital. Some of those projects are going to succeed, some are going to fail. Some are going to be quite long-term in nature. They're going to require co-developing, piloting, trial and error, iterations, time outside of the day-to-day jobs. People are already busy. Other things that we've heard, they're going to require getting over the bias that technology can be better than a human interaction, which is something that's not everyone is used to or comfortable with, especially in healthcare. So the list, we have competing priorities, things that are more pressing. Yes, this is the future, but it's not right here, right now. So how do you take that simple statement about fearing inaction more so than failure and actually integrate that into the culture of the organization? So you've already mentioned a few things. It's one of your 4 overarching principles. You've got a chief innovation officer that's also the chief medical officer, so tied in on both sides. You're involved at the board level with full buy-in from the CEO. So those are certainly a few starting points, but how do you proliferate that across 45,000 plus employees, 14 systems, given all the other points that I raised and all the other competing priorities?
So one is, we like to say that our innovation strategy is our quality strategy, is our IT strategy, is our virtual health strategy. So the overlapping Venn diagram of responsibilities for executives in our health system is there. The group of people that decide on what we're going to do and what we're not going to do is not just me. It's other direct reports to the CEO. It's myself, the chief strategy officer, the chief information officer, the chief nursing executive, and the chief financial officer. We all together stack hands and decide this is a priority and this is what we're going to do. And that means that I'm not doing something to someone else. We're doing it together. And when we do it, we say things like, if we're going to give a doctor or nurse one more thing to do, we're going to take 2 things away. We don't do pilots because I think that innovation gets suffocated by pilotitis. We do phased deployments. And we use our integrated healthcare system as a learning laboratory. So we have a single, mature, robust instance of Epic. That's our electronic health record. It is not highly customized. It's foundational and frequently updated. And we have, of our 14 hospitals, we have a megatropolis quaternary academic hospital. We have regional medical centers. We have community hospitals, and we have small and critical access hospitals. So everything that exists in American healthcare, we have in our system. And we use our system as a learning laboratory. So we do differences in differences, implementation science, and we think about how to optimize and scale. We pay attention to change management, cultural transformation, and workflows. So a great piece of technology that requires people to go outside of their workflow to use it is not going to get used. So we won't do that. So we've become expert at integrating into workflows, integrating into our electronic health record. And we've developed the social capital where when we do something and it doesn't work, people know we're not going to force function it. They know that we're going to iterate and we're going to call it if it doesn't work. And when it does work, we're going to identify the early adopters, ensconce them in resources, and disproportionately celebrate.
How do you measure results? In the example you gave us with the incidental findings, it sounds like you've got a better system for tracking incidental findings. You can probably measure how many times that comes up, and that's one version of results. But How do you think about quality control? How do you think about ROI, not just financial ROI, but patient healthcare ROI, patient experience ROI? Is there a data infrastructure that you have set up across the organization that allows you to have unique perspective on results of these different projects that you have rolling out across your network?
The key really is when you start identifying what success looks like. So it's not as though I have a separate, distinct data structure just for innovation. It's that we have identified what data elements are going to define success, whether it's changing mortality, whether it's identifying an attributable process measure that has an evidence base behind it that's associated with outcome, whether it's patient experience numbers, whether it's hardcore ROI. It's really about saying, we've started this project, we're going to implement it, and we will define success at 6 months if this number of providers have touched it and used it. They use it more today than they did yesterday. We have this level of revenue generation or this level of mortality. It's really the early identification of markers of success and everybody agreeing that that's how we're going to judge ourselves.
Is there a pretty standardized operating workflow program and system structure across your 14 sites, or at least the ones that are comparable? I know you mentioned a few different types of sites. Or do you find different workflows if you go to different local regions?
I'm very fond of saying that we have 496 special flowers in our healthcare system. But if I went 5 years ago, we would have 1,500. So as we become more systematized and we are an operating company, we become less variable. So our institutions are more similar than they are dissimilar, but there are certain nuances that are clearly different at some of our institutions than at others. But the approach is the same.
So I want to step back and think about UC Health, but also think about the broader healthcare market and really the broader health system market. And so I have this image in my head of almost like evolution, that UC Health has taken on different initiatives since you started this innovation program. Some succeed, some fail, but survival of the fittest, the ones that are strongest and yield results, get adopted and get integrated into your DNA, your program. And you then have a new hospital system, a slightly tweaked system. And then the next innovation gets adopted. And again, you have a similar sort of milestone of innovation and evolution. It sounds like UC Health has traveled over time and is no longer who UC Health was before, right? You've got the technology you spoke about. You alluded to the virtual health program. Until those things existed, they did not exist, and now they do. Where is this program in terms of its maturity? Are you sort of at toddler phase? Are you at adolescent phase, adult phase? How sophisticated, how mature is the program? That's question number one. And then question number two, how far will this evolutionary track travel over time? Do you see, 5 years from now, 10 years from now, you pick a time that the UC Health of tomorrow is going to look vastly different, almost like a new sort of subspecies has emerged? And if so, what are the key areas that you think are likely to change from where UC Health is today?
So I'll answer your question in a different order.
Sure.
One is, we're never going to be done. Like, this is not something that's done. I'm never going to sit here and say, we're done, we're complete. This is the way we're always wanted to be, and this is the way we're going to be. I may die before that, but that's not going to happen. It's interesting that you describe are you a toddler, are you an adolescent? We describe every project in terms of crawl, walk, run, right? So in some ways we are running, in some ways we are crawling. So in the adoption of using our electronic health record as a tool to execute on our quality strategy, we're running. Like, we are absolutely running. I would put maybe one or two other systems in our category. In the adoption of AI as a tool, we are just beginning to think about how to crawl. So we have lots of different verticals, and in some we're very mature, and in some we're just fledgling. And we will never be mature in every single thing at the same time. Otherwise, we just stop trying.
And how about in terms of the areas of change? Do you see some part of UC Health that if we look 10 years from now, it'll look vastly different, almost like a new version of a hospital system has emerged?
I think that in 10 years, we will look vastly different across a number of verticals. So we're looking at, what does a general med surg unit look like? So what's happened over the last decade will continue to evolve, which is more patients will be convalescing at home, being cared for at home. More things will go from inpatient to outpatient, and the acuity of patients that are in the hospital will continually get higher and higher and higher. That is a fact. And how we respond to that will have to involve technology, because we just don't have enough people to do that kind of work. So we will look very different in 10 years than we look now, the care that we deliver will be different in that we are going to be doing things in the home and in outpatient areas that we do now in the hospital. We're going to be using technology where currently we use people, not replacing people, but where we use people now.
It reminds me of another point of resistance that we typically hear, particularly in the health system market, where the incentive structure is not necessarily set up for hospitals to push to outpatient, to push to home care, to push to technology solutions. You're describing something very different. You talk about almost a slimmer traditional hospital footprint focused on the highest acuity patients, and then a surrounding ecosystem and network that tries to treat patients at home in outpatient settings through technology, so on and so forth, efficient, cost-efficient, high patient experience. Why is it that UC Health is able to do that? Do you have a different reimbursement, a risk-based reimbursement model that supports that? Or is this, again, just one of the core principles that your leadership has set out for the system?
It's a core principle that the leadership has set out for the system. We're 85% fee-for-service, and our risk profile is growing, and we're preparing for it. But compared to other states and other systems, we're largely fee-for-service. We are privileged in that we have a high demand for our services. So if I can move a lower complexity patient to the home or to a lower complexity environment, I can bring in a higher complexity patient. So from a financial perspective, that's usually beneficial. We also fundamentally believe that healthcare cannot be the last bastion of industry where deploying technology increases cost and complexity.
Again, I wonder, if the fact that your origins are relatively recent, back to 2012, I wonder if that helps. There probably was a lot less overbuilding of physical footprint since you were building in the modern era. I mean, this is a system that existed post Affordable Care Act and has, sort of been in the in-network paradigm of healthcare. You knew what you were getting into when you built those 6 de novos, and perhaps structured your sites accordingly.
Yeah, with the exception of office space in the city of Denver, there has not been any overbuilding in Colorado. The population explosion has been such that, if anything, we're still behind and catching up.
Last question. You talk about partnerships with technology providers. How about partnerships on the innovation side with non-hospital provider groups? So large MSOs, specialty care. Does that play into this, or is everything that you're looking at from an innovation perspective really within the employed physician physical footprint of UC Health?
So we have all types of providers. We have employed providers, we have faculty providers, and lots of independent providers. From a payer perspective, we have lots of fee-for-service and lots of governmental and risk. From a partnership perspective, our ideal projects, our ideal programs are one where we bring 3 or 4 different partners together. We're a healthcare system. If we bring a technology partner, big tech or little tech, and a payer partner together, that trio can be pretty magical. If we bring pharma into that what's a trio, quadro or a quartet, can be pretty remarkable too. So the fastest moving, most attractive partnerships to us are where we have 2 or 3 or 4 partners together.
Yeah, I actually have one more question, so I guess I lied. I think about, I did an interview recently with the founder and CEO of Hopco, the large ortho MSK national player. And it was interesting. They've really transformed from a owner and operator of physician practices and acquirer of physician practices to really a managing company. And so they built clinically integrated networks. They have hospital partnerships where they manage the ortho MSK service lines for these hospitals. And they also have their owned practice network. So they have sort of 3 go-to-markets. And I say that to say that they've really transformed and transcended to become a management company focused on ortho MSK best practice excellence. I hear a lot of that in UC Health, right? You've got sort of a program that allows you to manage a modern day health system that allows you to have best practice for innovation. Does UC Health ever transcend its role from being an operator of health hospitals in Colorado to be more of a managing company focused on hospitals irrespective of geography, or do you see the focus continuing to be within the Colorado market? Maybe you add on site 15, 16, 17, but that's sort of the parameters that we're looking at here.
Right now, we are focused on Colorado and the adjacent states. Mm-hmm. So the proximate is Colorado and our adjacent states. Who knows what the long term is as there's more coalescence and more, I was going to say collusion, but that's not the right word, more cooperation across states. A lot will be dependent on what the regulatory future looks like for us.
Thank you so much for your time. This is a fascinating conversation, and some of the things that I'm hearing about how UC Health and how you are approaching this question of innovation are very unique. So I really appreciate it.
Well, my pleasure, and thank you for having me.